Friends, welcome to my hospital at Ranaghat, India. This is a hard cataract, nuclear sclerosis about grade 5 being done under topical anesthesia. This is the main incision on the posterior aspect of the limbus. This is a 2.8 millimeter keratome. And now, one side port is being made on the right side of the main incision about 3 clock hours away, and one more side port is being done on the left side about 2.5 clock hours away. And now, this is an air bubble. I want to stain the anterior capsule of this cataract and apply the dye underneath this air bubble. Staining of the anterior capsule becomes almost immediate if you use an air bubble. This is a bit of adrenaline to see if the pupil dilates little more. And yes, it has dilated little more in this case. And now 2% hydroxypropyl methyl cellulose is being injected. The antechamber is filled up with this viscoelastic substance. And now capsulorhexis is to be done. I take help of a 26 gauge bent needle, incise the capsule and raise a nice flap. Now I hold this capsular tag with utata forceps, go anti-clockwise and perform an adequate sized rhexis, and in hard cataract it is about 5.75 or 6 millimeter, because management of nucleus becomes very easy if the rhexis is large. There is less stress on the geniole and the pieces come very easily. Now hydrodissection is done at multiple points. Small amounts of fluid is injected at multiple points. The nucleus is tapped and it is mobilized. Viscoelastic substance is again injected, and now is the time to introduce the tip of the phaco handpiece. And here you are going to see the technique which I call Submarine Job. It's a kind of direct job. Push the nucleus little down. First remove some superficial cortical matter. Now after removing this, with the help of this chopper, push the nucleus little down towards 6 o'clock, and here you go into the substance of the nucleus, go through the nucleus, break the spine of this hard nucleus and go near the opposite equator, and then you apply your chopper and divide this, and see how beautifully you can divide this hard cataract. Rotate it 180 degree, hold on pace with vacuum and separate the two heminuclei completely. Now since this is a hard cataract, in this case I am dividing each heminucleus into 3 pieces. This is one piece, and this bigger piece is being divided into 2 pieces. So this heminucleus has been divided into 3 fragments. And now this is the other heminucleus. This is also being divided into 3 pieces. This is one piece, and the bigger piece again divided into 2 pieces. And now I am going to emulsify these pieces and remove them. From the very beginning I am in phaco 2 mode, where the ultrasonic energy is 80%, flow rate is 45 ml per minute, and vacuum is 450 millimeter of mercury. Yes, from the very beginning I am in FACO 2 mode. And now each nuclear fragment is being emulsified and removed. Dear colleagues, either you learn this technique or you buy a femtolaser and soften the nucleus to make your job easy. That's it. The nucleus has been nicely managed. And now 2% hydroxypropyl methyl cellulose is again injected. A 23 gauge Simcoe cannula is used now to remove the cortical matter. You can use a coaxial IA or bimanual IA. But this instrument is very safe in the hands of the beginners. And after you have done some cases, you can go to bimanual irrigation aspiration. That's it. The cortex is nicely removed. Actually, in this case, there was a very little cortex because most of the lens matter has been incorporated into the nucleus. And now the antechamber and the capsular bag is filled up with viscoelastic substance. And now I want to check if I have removed the cortical matter nicely. So I am retracting the iris with this instrument which is shaped like the letter Y, and I find that I have removed the cortex very nicely. And now a hydrophobic acrylic intraocular lens is being implanted in the capsular bag. This is a yellow tinged aspheric intraocular lens from Appasamy Associates. No financial interest, but this is a very good lens. And now the visco that has been used has to be removed very nicely. So the antechamber is irrigated first, and then I go behind the nucleus, irrigate the capsular bag. Just by this irrigation, thorough irrigation, most of the viscoelastic substance comes out. And then irrigation and aspirating probes are used simultaneously. Like this. And use these both for some seconds, for few seconds. You can see that the pupil has been constricted a bit, and the size of the pupil is about 4.5 millimeter at this time. But our job is done. And now antechamber was becoming shallow, so I have injected an air bubble to keep the antechamber formed. Now I am injecting some amount of moxifloxacin, and then I hydrate struma on either side of the sideboards to make these stab wounds watertight. That's it. Now we are towards the end of the surgery, and this is the final lavage of the anterior chamber with a 23 gauge Simcoe cannula. Remove the air bubble, thoroughly irrigate and then aspirate the anterior chamber. Form the antechamber like this and check all the wounds. There should not be any leakage from any wound. All wounds should be watertight. And then conclude the case. Thank you very much for watching. Hope this video will help you in developing your surgical skills. Be better and do better.